Yeah, just my take on things. My answer to number two. Guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Those cognitive distortions decrease until they cease. Let's go. Guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release.
I think we're recording. Welcome, everybody, to Peplow's Ghost, another exciting episode here as we move through the summer. Hopefully, you're enjoying some warm weather wherever you may be, but really excited to have our next guest here, Dr. Beth Phoenix, who's going to be here and sharing her views on using psychotherapy and kind of her general experiences and such. Really pleasure to have Dr. Beth Phoenix here on this podcast. She's, one of the trailblazers, as I may, hopefully not offensive, but a living legend, in my opinion, within the psych mental health nursing community. I took a couple notes before we got going. So she was the president of the APNA, the American Psychiatric Nurse Association. That was back in 2012 to 2013. So did some amazing things there, and has actually in 2023, I've forgotten how, it's amazing. I thought this was just last year, but 2023, she was nominated and voted for to be the APNA Psych Nurse of the Year. That's huge. I mean, just to kind of think of all the psych nurses, you were number one in 2023. So, so great. And again, hopefully, if you don't know Dr. Beth Phoenix, maybe you can look up her bio. She's very well known around the University of California, San Francisco, where she did a lot of her training, was a program director there for a while too. So again, thank you very much, Dr. Beth Phoenix, for joining us. And I'll just kind of get us going and talking about our favorite subject, psychotherapy. So when did you get interested in psychotherapy as a concept or as a skill? When did you start to notice that was something you wanted to devote most of your life to?
So, my history is a little different than a lot of people you've interviewed on this podcast, because when I was in graduate school in the late 80s, the director of my program was I was in a CNS program, and the director of my program did not think that that psychiatric CNSs should be trained in psychotherapy. She thought that nursing was focusing too much on what she called the worried well, and that she really felt like we needed to focus more on people with severe and persistent mental illness. So the focus of our training was really much more on psychosocial rehabilitation for people with severe and persistent mental illness. And so, a big part of that was group, delivered in groups. So that's when I really first got really interested in groups and, started to understand how important it was to have for nurses to have skills in leading groups.
Great. Do you know what was about groups that was so fascinating, or was just part of the program and you just got the bug and it bit you?
Well, what I really liked about use of therapeutic groups was that the therapist didn't have to do everything. I mean, a lot of the therapeutic effect of groups is from group members' relationships with each other and what they learn from each other, and how they bond with each other. And I just found that to be kind of a more empowering, a form of support for people, because as the group leader, most of what you're doing is facilitating people's relationships with each other. So that was something that really appealed to me, and kind of helping people benefit from the wisdom of the group.
Yeah. No, that's great. I don't know, and I forgot to introduce my my co-facilitators as well, Dr. Sean Convoy from Duke and Dr. Kate Molino from also California, University of California, San Francisco. But yeah, before I became a nurse, I was a program director for the partial hospital program, which was primarily group based. And I agree, that's always been the relief of of doing group therapy is that you don't have to have all the answers, and probably somebody within the group is going to have a better answer and a better way of saying it than ever I could. So I just need to make sure I don't get in the way of the process. And I really like the idea of not always in my program, I tell my students, you're not a group leader, you're a group facilitator. I like that idea. And you don't lead the group, you just facilitate that conversation. And like I said, just try to get out of the way when you can. So, all right, I'll turn it over to Sean.
Yeah, a great opportunity. We were talking about this before we went live about, how we would necessarily operationally define psychotherapy. Do you have any thoughts about that?
I do. Because I think people have a lot of assumptions about psychotherapy. I mean, I think people think 50-minute hour. They tend to think of individual therapy kind of exclusively. So I decided to do a little AI experiment. So I asked the Google AI thing to find like 6 definitions of psychotherapy and then summarize the common elements. And this is kind of consistent with my observations, so I don't think any of this is hallucinations. But some of the things that, were common were, that it involves communication, interaction with a trained professional, focus on thoughts, feelings, and behaviors to address a variety of mental health and emotional challenges, coping skills and problem solving, value of therapeutic relationships, and a safe and confidential environment. And so none of that is a 50-minute hour. None of it is a particular, type of psychotherapy. So, I think often the way we think about psychotherapy is a little bit too narrow. And as we'll get to later on in this conversation, I think this is important in thinking about the ways in which advanced practice psychiatric nurses are leaders in psychotherapy.
Yeah, it almost sounds like, if I understand you correctly, you're kind of saying that psychotherapy is consumed within the discourse of the therapeutic relationship.
Yeah.
Yeah. Cool.
Yeah.
That's a good way to think about it. I'm gonna take you more directly towards a practical experience. Was there one particular experience that you had as an advanced practice nurse that kind of gave you the bug that, wow, there is something magical in this psychotherapeutic process with a patient? Can you de-identify and share the story with us?
Nothing's coming to mind. I mean, I've had so many of those experiences throughout the years. I mean, I think one of the things that really struck me, because I've done a lot of kind of psychoeducational kind of groups, is the impact of universality when people find that they're not alone with their problems. Because I did many, kind of psychoeducational groups on depression. And I can't tell you how many times, when we were kind of doing our checkout and, people were talking about what they got from this first session of the group, people would say, I did not realize there were so many people that had the same problem as I do. And I always thought depressed people were kind of downers, but the people here seem pretty cool. They have great senses of humor and they seem pretty smart. And so, that was something that really impacted me, that it's a kind of a simple thing, but it really makes a big impact on people.
That's awesome. I hear tales of Yalom's curative factors coming over this conversation, right?
Oh yeah, baby.
Kate, what do you got, my friend?
Hey, this is Peplau's ghost, not Yalom's ghost. I think he's still alive too.
I think he's
okay.
too, yes.
So I shouldn't have put him in the grave like that. I apologize. Sorry.
So, Beth, I'm wondering, you mentioned that you've, done a lot of psychoeducation groups, and I'm wondering for our listeners out there, if maybe you could elaborate on sort of, were these groups focused on a particular topic? What types of settings did the groups that you've run take place in? Like, give our listeners a little bit of a overview.
Yeah, I've actually done these kind of groups in a lot of different settings. For a while I was doing them in a kind of community-based residential treatment.
Mm-hmm.
I've spent several years doing primarily groups in a stimulant drug treatment program. I did many years of psychoeducational groups in a big health maintenance organization. So the focus of the groups, I mean, obviously in the substance abuse treatment program, the focus was on substance use recovery. In the HMO, I did a lot of groups on depression, anxiety, ADHD, insomnia. I think I did a couple on anger management. So a lot of different foci, but kind of, I think, similar strategies or skills that these groups focused on.
Yeah, thank you. And I think going back to what you said earlier about how sort of what I would term these common factors in psychotherapy are so important. So much of, I think sometimes we get really bogged down in the details of exactly what type of techniques we're using, but important to kind of pare it back. And maybe going back a little bit to Yala, what are some sort of principles or guiding lights that you have used in your groups to facilitate change?
Well, I think a real important role of the group therapist is to really help people in the group make connections with each other, because I think that's where a lot of the therapeutic benefits of groups come from. So kind of helping people see things that they have in common, or, things that they may have a common problem, but kind of different ways that it manifests for different people. One of my colleagues kind of talked about a big focus of groups being able to identify differences within similarities and similarities within differences. Universality, just people in a lot of contexts, feeling that they're part of a group, for people who've been socially isolated, that value of group cohesion, I think can be very therapeutic. The way people learn from each other, it's kind of like, oh, that person is struggling with the same problem as me, and they tried this and it worked for them. Maybe I should try that. I think a lot of those things, are very impactful.
Yeah, thanks, Beth. I mean, I'll say thank you too. I think you've come up with our title for this episode. I love that idea, the similarities within the differences and the differences within the similarities. That's very just succinct and kind of really streamlining what we're doing here in this kind of work. So I think you were hinting at kind of our next question, which I want to get into as you're, one of the, stellar nurse leaders here. How do you see nursing being a leader in performing psychotherapy or doing, group psychotherapy and such?
Well, I think that nursing is a leader in kind of flexible application of psychotherapeutic techniques, often when we're kind of doing other things as well. Like I was on the APNA workforce task force a few years ago, and I actually went back and looked this up, but 69% of the advanced practice nurses that were surveyed said that they used psychotherapy in combination with prescribing. And I don't know what those statistics are like for other prescribing professions, but I suspect that that's a lot higher. And I've heard people on this podcast, like Kate talked about, kind of modifying, the time frame for psychotherapy sessions based on the needs of the population. Chelsea Landelin was talking about how you can kind of incorporate cognitive restructuring into a brief medication visit. I think nursing is a very pragmatic profession. We kind of, despite whatever circumstances we're in, we kind of figure out how to do what works. And I think that this is a practice pattern that both allows people to receive combination therapy, both medication and psychotherapy, which much research has demonstrated is the most effective for many different kinds of mental health conditions. Um, and also because, nurses are kind of ubiquitous across the health system, it kind of allows us to bring psychotherapy into settings where it might not otherwise be, like primary care. Um, so I think that's an area where nurses are really taking leadership, and I think it's kind of a matter of framing because I think people sometimes kind of bemoan, oh, we don't have enough time to do appropriate psychotherapy, but I think you can apply psychotherapeutic techniques across a variety of types of interactions. And nursing is not, we're not like real dogmatic about, any particular kind of psychotherapy. It's kind of like if it works, we use it. Um, so I think that that's something that we ought to be tuning our own horn a bit more about. Um, our flexibility, our pragmatism, and our ability to deliver effective treatment to people with a variety of different conditions across settings.
Wow. Let Dr. Phoenix cook. That was great. That was amazing. Yes, I love it. Because there's so many things there that you just said that just kind of really resonated with me. Just this idea of not having, and you said this earlier too about 50 minutes session is not the it's not the framework that we all need to be thinking about for doing therapy. And I know when I've said this to other professions, I really get kind of this prickly like, no, it's got to be an hour. That's what this, you only get good therapy when hour. No, I disagree. I mean, I don't think it takes an hour to do therapy. It's, you can do it in a half hour. I mean, I don't know if you can do it in 10 minutes, but I mean, there is kind of, and I love how you just kind of said that being very flexible, with nursing. I mean, I think that's, nursing as a holistic science, very caring science. You're right. If we find something that works, we go with it. But I wanted to kind of maybe follow up and ask you a little bit of a question, just your thoughts on it, because I had this discussion just before we started recording, that a lot of providers that I talk to, they're doing therapy within their practice, just like you mentioned, that integrated, med management therapy type of role, but they don't take credit for it. They don't count it,
Mhm.
they don't count it either for billing or they just don't say that they're therapists. And for something about that, and I think you mentioned that maybe they're scared to do therapy, but is there something else that seems limiting to you that why people don't kind of take that ownership that they are doing therapy? They just don't own it in a sense.
Yeah, like I kind of indicated before, I think the whole concept of psychotherapy has been mystified a little bit. I mean, I think when people think about that, they tend to think of more in-depth psychotherapeutic approaches that are, that you kind of do need a little bit more time for. But there's certainly types of psychotherapy, and I think these are the types that tend to be most used by nurses that, that you can kind of integrate specific techniques into a variety of interactions depending on the needs of the patient. I mean, for instance, if you're seeing a patient for med management and the patient's kind of ambivalent about taking medication and their adherence is not great, you can use a motivational interviewing technique like a decisional balance. What are the things that you like about taking medication? What are the things you don't like? Kind of explore that to improve adherence or maybe to kind of figure out that you need to change your prescribing regimen. And you can use cognitive behavioral techniques like cognitive restructuring. um, Maybe you're seeing a patient with a medical disorder like diabetes in primary care, and some of their dysfunctional and distorted beliefs about diabetes are interfering with their adherence to that medication regime. So, I think there is this idea that somehow that there's kind of nothing between novice to expert. And I just don't think that's how people learn psychotherapy. I mean, I think you can, I mean, I'm really in a lot of ways kind of largely self-taught in terms of what I know about psychotherapy because I didn't learn it in graduate school because, it was kind of like the T word was, kind of not what was on offer there. But, from kind of using manualized psychotherapy, I've kind of learned how to use specific techniques. I've kind of been able to refine that, using supervision and that kind of thing. Um, so I think having, more of an idea of kind of building blocks, we're going to teach you some techniques. You can continue to learn more techniques and how to appropriately apply them after you get out of school. Um, so I think that's kind of one thing is just people having this kind of overly restricted idea of psychotherapy. I think the other thing is there's not a real clear border between our normal therapeutic interactions with patients and psychotherapy. I mean, like some types of therapy approaches like supportive psychotherapy are very similar to kind of just the regular things that we do in any encounter with patients. Some of those, techniques like, encouragement, advice giving, those kind of reality-based techniques. So I think some of it is kind of a framing issue. But I do definitely think that's something that we need to start claiming a little bit more. Being able to identify, yes, I've established a psychotherapeutic relationship. I've kind of done an assessment. I have goals involving psychotherapy, and I'm doing it, and I should get reimbursed for it.
I think I quite frankly, as you're talking, I'm hearing a manuscript come out about deconstructing the historical
Mhm.
boundaries about how we operationally define psychotherapy and
Yeah, great idea.
frankly nursing writ large, right?
Hmm.
To some degree. I agree with you, Beth, that most of what I learned was watching those old videos from Carl Rogers and Aaron Beck in the 1970s, most of which are black and white. I learned more from them than I think I have in any formal classroom environment.
Hmm.
I'm gonna ask a question. I'm gonna ask all of you, three of you, to answer. I'm gonna start with Kate, then I'm gonna go to Dan. I'm gonna finish with Beth. I'm currently teaching psychotherapy this semester in my summer semester, and this is kind of the most enjoyable time of the year for me because of it. I see a common pattern working with students, and if there's like one student in my cohort is listening right now, hello. I'll share that one of the most common challenges that I encounter when I try to teach individuals psychotherapy from the ground up is that there is endemic in the nursing role is this tendency to be the fixer. And I'm constantly working with them to shed loose the fixer role to transition to what Dan said earlier, the facilitator role. And that role is so well entrained or entrenched for traditional registered nurses and also primary care nurse practitioners that I'm interested in everybody's thoughts about how I can break through that fixing mentality, shifting to the facilitating. And I'll start with Kate. What are your thoughts, Frank?
Sean, what a great question. I also am teaching psychotherapy this quarter. So yeah, we're in week 3, and this is one of their first specialty classes, actually. So something I've been trying out, and of course we'll see how it bears out over the term, but something I've been trying out is trying to make an analogy, I suppose, in terms of shifting the concept of what they're doing from sort of acute treatment to chronic disease management. And so calibrating the notion of what is success, how do we set goals that are realistic, thinking over the long term. And I have found with some of my students that I can see the light bulb going on. So yeah, that's my thoughts on that.
That helps. Dan, what you got, friend?
Yeah, no, great question and great answer, Kate. What I will say is probably a little more pragmatic. When we run into students that struggle with this and want to fix everything, we just tell them to shut up. I mean, not so bluntly, right? But it's really about, bite your tongue, get comfortable with being uncomfortable of not saying something. Because again, like we talked earlier about that facilitator role of just kind of being quiet and letting them come up with their own solutions. Sometimes they do a fantastic job of that. So sometimes we don't have to have that magic, saying. I sometimes blame a little bit of a TV and movie on this, right? You see psychotherapists and, famous like, Freud or something, and he says something that's just amazing and it comes right off the cuff. And I'm just like, of course they spent like 6 months in a script room trying to figure out what this, how to say this exactly right. So you're not going to come up with that every time. But that's when you were talking about this, Sean, that's my initial thought is, if they want to fix, they want to get in there, they want to kind of say something that's magical and, solves all their, 25 years of trauma that they've been experiencing. That's just not going to happen. Let them kind of be there. And again, learn to get comfortable with that uncomfortableness of biting your tongue and not saying anything. So yeah.
Great.
Yeah.
I'm going to take it to our elder stateswoman. What do you got, Beth?
Well, I think you really put your finger on something, because I think nurses by nature are action oriented, and I think that that a lot of, since most nursing training at the pre-licensure level is in acute care settings, you're not there to kind of negotiate goals with the patient. You're there to do stuff to get them better. And a lot of what you're doing is you are acting upon patients. But I think psych is, except for people when people are at their most decompensated. I mean, a lot of what you're doing is really more motivational. And I think, like Kate was saying, that kind of gear shift from, acute management to, kind of long term, helping people learn how to manage their own conditions. I mean, I think that's a real gear shift for people. So I think that has to be really called out, just in terms of what people's role is in this kind of context. There was something else I was going to say. I think also sometimes you just have to raise the issue with people of kind of their own need to fix people. And that as nurses, it is part of our kind of ethical responsibility to kind of respect people's own, goals and desires. So I think sometimes people do have to kind of look at what it is in them that's so determined to fix people, because that's a recipe for burnout in the long term, because you can't fix people. People need to fix themselves. And you can help, you can support, you can cheer on, you can help people learn skills, but ultimately, people are autonomous, and they, it's up to them. So I think kind of, that readjustment of what you think of that your role is really important. And that's why I'm just going to throw another thing in here. That's why this advice that you should do your year of med surg before you go into psych is not good preparation for going into psych, because psych is a different mentality.
Mm-hmm. Yeah.
Well said. Before I pass it to Kate, I'll just say I agree. I appreciate everybody's feedback, and I particularly connect with what you said, Beth, because I personally think that carrying this fix-it mentality into advanced practice psychiatric mental health nursing is an example of our unchecked countertransference.
Mm-hmm.
Mm-hmm. Absolutely. Yep. And
yeah.
I'll just share that as a former student of Beth's and later on her colleague, Beth wrote the mission statement for the Psych NP program at UCSF, of which an important part is that tolerance for uncertainty and ambiguity is something you must cultivate in your advanced practice role, which I think is so important. And I love that she would read that out loud at the beginning of every year. So Beth, I'll ask you our final question for today, which is, how do you see the future of Psych NPs, advanced practice psych nurses, using psychotherapy?
Yeah, I think basically kind of continuing to do what we're doing now, but claiming more ownership over it. I do think it's extremely important for psychotherapy to continue to be taught and for for certifying bodies to require that Psych NP students get supervised clinical training in psychotherapy because, it's basically, um, it's basically part of the, kind of toolbox that you have for working with people who have mental health conditions. Um, I think, kind of being more intentional in terms of how we talk about psychotherapy and the types of psychotherapy we use, how we use it, the skills we have, articulating that to the public, to payers, whatever. But I think kind of demystifying it for students, giving students more confidence that, you kind of start small, you learn some techniques, you try them, you refine them, then you learn more techniques. It's not like some big jump from novice to expert. Um, I think those are some things that are important for the future. But because evidence-based psychotherapies have such a strong track record of helping people get better, it is crucial that it continue to be part of Psych NP practice.
Love it. Wonderful. Thank you. Thank you. Thank you, Dr. Beth Phoenix, for being our guest here on Peplau's Ghost. Please look forward to other episodes that'll be coming soon. And again, thank you, Dr. Phoenix, for just really helping us demystify this role of psychotherapy within the practice. So, all right. Take care, everyone, and we'll see you at the next episode. Like, subscribe, and comment, please. Bye-bye.
Too much salt like this, too much seasoning. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. Guided discovery, identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease. Yeah, guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease.